on the COVID-19 vaccine or what you've heard about it. So today we will have a few guest speakers and an opportunity for a little Q&A for those who are on the call. At this present time, we have 53 folks dialed into the call, so that's a fairly large amount of folks here across the region. And by the looks of the names, we have everyone from traditional hospital, a few frontline staff and managers, out to our HPP coordinators, EMS liaisons, EMS managers, CEOs, and the like, local health departments. So we have a varied group of folks here, and local emergency management agency personnel. Now we're up to 55. So again, in the interest of time and effort, we want to make sure that we have enough time so you can have some of your questions answered. So once we start the presentation, we'll try to make it through the entire presentation first before we open it up for Q&A. Again, if you are using Microsoft Teams, please use the raise your hand little tool, so that way I can effectively manage those folks who would like to ask a question, and we can do that. And then we'll try, if you have just called in directly via phone, we'll try to manage that as best we can as well. So please stand by for that. And all right, so I'm going to move our slides. Hopefully everyone can see the slides that are here. You should see a slide that says IDPH, Illinois COVID-19 Mass Vaccination Planning, October 7, 2020. So if you don't see that and you're logged on the computer, please shout out. That way I know that we are actually broadcasting live. So I will, with the blessing of IDPH, be able to provide these slides later. So please stand by for that. But without further ado, I'd like to introduce Dr. Carla Little. She is the State Medical Countermeasure Program Manager for IDPH in the Office of Preparedness and Response. Dr. Little, she's been with IDPH for some time, and she does great work. We've been working together for the 5 years that I've been here, and I truly appreciate the time and effort she's put into the Medical Countermeasures program and trying to keep us on track. While she won't be our full speaker today, I will allow her to introduce our speaker, but she's the one that we work with day in and day out with regard to all strategic national stockpile distributions, all our RSS sites, et cetera. So she's done a lot of planning and for the state of Illinois, and we appreciate her time and effort in taking it out today to join us here at the Hope Coalition down here in Southwestern Illinois. So Dr. Little, if you're on, can I hear you say a little bit of something before we get started?
Hey, Phil, thank you. That was a great introduction, and thank you for the invitation to present to the Hope Coalition. I'm Carla Little, as Phil mentioned, on the call today. So as many of you guys know, we've been working on the COVID-19 mass vaccination administration plan for the last few months, and it really kicked into high gear at the beginning of August. Gina Lathan, who also I believe is on the call, she is our immunization section chief, and she and I have been co-leading mass vaccination planning, COVID-19 mass vaccination planning, as well as really all mass vaccination plans that we have in place for the state of Illinois. So Gina and I have been working on this together for the last couple of months. As I mentioned, recently we brought on board Paula Jimenez. Paula had previously worked for IDPH and recently retired from the Office of Health Promotions. She has an extensive background in vaccine administration from a corporate perspective. So she came back to us on a 75-day contract to assist with the COVID-19 vaccine administration planning, and she's her specific role is working in outreach with local health departments, hospitals, and other providers. So I'm going to turn it over to Paula Jimenez, and she'll give the presentation today, and then there's several of us from the statewide COVID-19 mass vaccination work group and team on the call that can answer some of the questions during the Q&A session. So Paula, if you're on the call, I'll turn it over to you. Is Paula on?
Paula, if you are speaking, you are currently muted.
Well, in the interest of time, while we're trying Paula unmuted, I'll send her a text and see what's going on, but I don't want to hold anybody up. So I can begin to speak. Gina Lathan, are you on?
I'm checking down the list of names. I don't think I see Gina's name, and I don't have her direct line on here to check. So.
Oh, she said she's on.
I'm wondering if I'm checking all the lines. Unfortunately, I can't directly unmute any line that might be.
Yes.
Well, technology being what technology is, I mean, we wouldn't have a good call if we didn't have a little bit of right. So yeah, and I see someone just chimed in saying, "Hey, press *6 to potentially unmute." But I'm not showing a lot of. Looks like all our cell phone callers are. Look like they're all unmuted now, and they're using their personal mute buttons instead of the *6. So,
Okay, well, I'll go ahead and get started while we work through the technical difficulties, if you don't mind, Phil.
No problem. I'll just move the slides. You let me know when, and we'll get started. And if Paula can get unmuted, we will continue.
Okay. Okay, go ahead. You can go ahead and move to the next slide, which is the take-home message. Okay, everyone, thank you for your patience while we work through the technical difficulties, and hopefully we will get those figured out. On the Wednesday webinar that IDPH does, that has been doing with the COVID-19 response since almost the beginning, we presented a couple of weeks ago on the mass vaccination plan and where we were as a state and the things that we needed from our local health departments, hospitals, and other, especially priority providers, in getting some data to help better inform the plan and what's happening at the local level. So one of the things we ask is that you review and update your local mass vaccination plans to include the administration of the COVID-19 vaccine. So the local health departments and the hospitals, and to some degree, the Healthcare Coalition has been working on a pandemic response for a number of years. We were, if many of you that have been around, you know that we have been doing training and various exercises over the last 2 years in preparation for a full-scale pandemic exercise with influenza as the threat that was supposed to take place the week of October 26th. That's coming up. So we had a series of other exercises uh, since January 2018 that was leading up to the full scale exercise. In the meantime, we had COVID that started for us back in January. So many of you already have your mass vaccination administration plans in place. We wanted you to review those and update those in the context of COVID-19 vaccine administration because that's going to be slightly different from what we would do from a pandemic influenza administration. The priority groups are different. The types of vaccine that are being brought to market are different. So those are all things that we needed to consider. Like we were planning with the influenza vaccine versus COVID-19, we're expecting to mass vaccinate 80% of our population. To do that, we need to have certain programs in place. For instance, that second dose, that's similar to what we were planning for the influenza vaccine, pandemic influenza vaccine. So the second dose has to be tracked. So we are uh, looking to bring on board some of the CDC programs they're developing for this purpose, like the Vaccine Administration Management System, EM-Track. I think most of the hospitals and EMS systems are familiar with that. We can also use EM-Track for signing up or registering clients to receive the vaccine, and Dispense Assist is another product that's used for patient vaccine administration and patient registration. And I know it's being used down in the St. Louis Metro East area where you guys all are. So you may be familiar with that one as well. So wanted you to think about those things, what system works best for you, incorporate that into your plan. One of the other things we know is that because this is a fast-moving situation, all of the vaccine providers will need to report daily on their vaccine administration and on-hand inventory. That will be done in iCare, and it will be defined by the CDC. Also, we're asking that you include in your plans that all vaccine providers must share with the vaccine recipients the emergency use authorization fact sheets or any vaccine information sheets that would be given to us by the federal government for those purposes. And all providers must include in their plans procedures for reporting clinically important adverse events. There's an adverse events reporting system that CDC has put in place, and want you to make sure that's included in your plan, and then maybe even talk through how would you ensure that all recipients of the vaccine have access to that information. There's a website, and there's also a uh, hotline that vaccine recipient could call, or anyone could call if adverse events will need to be reported. That also can be reported in iCare, as many of you know if you're familiar and you use iCare. We're also asking that all vaccine providers register in Illinois Helps, the Illinois Health Alert Network, uh, which is Siren, and hopefully all of you are already registered users and recipients of Siren messages, because that will be the way that we share guidance information and any critical updates on the COVID-19 vaccination administration mission. The next thing we ask you to do is, once you've updated your plan, also identify any priority providers that are in your jurisdiction. We sent out to all of the local health departments and the healthcare coalitions for dissemination to hospitals and anyone else that they deem necessary, a list of all of those priority providers that we at the state level have identified, the local health departments, the hospitals, the long-term care facilities, the FQHCs, the prison, the Department of Corrections, correctional facilities, I believe the Department of Human Services, their developmentally disabled facilities. There was a wide list of priority provider populations that we had already started to work with and identify and enroll in eye care. And we sent that list out to you all so that you would have a copy and it was collated by the EMS regions, the public health and medical services region, the county, and down to the municipality so that you would know all of those priority providers that we at the state level had identified and we're working with so that um, you all could ultimately work together and coordinate. But also, if we missed anybody that you found in your region that is a priority provider, meaning that they would serve that population that's in the phase 1, phase 2, and phase 1A and B, and then parts of phase 2 of the CDC, the recent CDC guidance that came out. Then make sure you add those priority providers to that spreadsheet. That's really for you to keep, but also you can share back up to us if we missed any priority providers, and make sure then that they get enrolled in eye care. They ultimately, everyone that's going to administer the vaccine would have to complete and sign that CDC COVID-19 vaccine program provider agreement and profile form. Recently was released by the CDC. It just got approved by the Illinois Department of Public Health Legal, and now the eye care staff are working to get that. The IT staff that work with eye care are working to get that form. It's a fillable form that will go into eye care, and anyone that's enrolled in eye care will have the opportunity to complete that CDC vaccine provider agreement form to be approved to receive the vaccine. Then uh, as a result, once you've been approved and the vaccine becomes available, you will all have the opportunity to order the vaccine via eye care, and then the vaccine will be directly shipped to your site from the federal government in most cases, it will be via McKesson. The third thing is we ask that you calculate and estimate the number of essential personnel per provider. So we know, for instance, that I'm just going to give a round number, but for instance, Calhoun County has roughly 7,000 people. So we know the local health department has the ability, based on their plans, to they're going to open a certain number of pods, and they have a certain number of throughput, uh, daily throughput that they can reach each day. So we need to know that number. We need to know the total number of population that they would serve. If there's open pod or if there's closed pods like the long-term care facilities, I don't believe Calhoun County has a hospital, but maybe I'm wrong. But if there's hospitals or if there's long-term care facilities or other priority providers, we wanted you to estimate the number of what their total number of clients that they would serve, and then what's the daily throughput for that client, for that provider. So that's really number 3 and 4. So that's the information, and we wanted you to. I'm sorry, someone had a question?
Oh, I think that was just a little, I think that was some background noise
Oh,
from someone.
feedback.
Again, for the folks that are online, please make sure that your lines are muted, and then we'll go ahead and press forward. Go ahead,
Okay.
Carl. Thank
So
you.
so in addition to that priority provider spreadsheet that we gave you, and that's for you to keep and add to if needed, we also provided to you a COVID-19 allocation spreadsheet. And on that spreadsheet, that's where we wanted you to put all the providers in your jurisdiction, and then the number, what is their capacity? Like, what's their total number of the population that they're going to serve, and what's their daily throughput? Because we will use that number to inform the approval of the vaccine that you order in the system. We don't want any one provider to order more vaccine than they can use in a 24 to 48-hour period, because a lot of the vaccines, the way they're shipping it, for instance, if it's ultra cold storage, it's going to be shipped in its own self-container. And so we want you to be able to use it up quickly, and we don't want you to hoard it, because again, if you guys were around for H1N1, that was the problem that we found during H1N1, was that some jurisdictions who had the capacity to order more vaccine, they did, and then they weren't able to use it. So then you get a lot of waste of vaccine. And in the early days, especially of this COVID response, we want to get the vaccine into the people that need it the most. So we don't want it to be wasted. So that's the way we're going to use that information. And finally, we were hoping that because the Healthcare Coalition, like Phil, has such a wide reach as a lead, that we can you can help us to work with the local health departments and any providers to identify any training that's needed, anything that we can put together. I know you guys have a lot of expertise in the region that can be utilized for training on, say, if certain providers uh, would need training on how to administer the vaccine. Um, the local health departments could be a good resource for training on how to set up closed pods, things like that. We wanted you all to sort of collaborate together and think about what needs you have in your region, and then what needs can you feel fulfill yourselves, and what things we can do at the state level, so that we can all be working together and make sure everyone's ready for this mission. Another thing is working with the Department of Professional and Financial Regulations. You know, uh, they license many professionals, healthcare professionals in the state of Illinois. They're looking to expand the scopes of practice. So, for instance, if you know of retired nurses that you would bring back to help with administration of the vaccine, then we would want to know that information. And I think if you guys are talking as a group, as a region, then we can make sure that all of us are working together, and all of us are just kind of have a cohesive response to vaccine administration. I'll pause for questions there. And I think we lost the slides, Phil.
Yeah, I just saw that, so I'm trying to bring those
Okay.
back up. So if you guys again, if you have questions, I did see just a few pop up in the chat window a second ago. So I'll start with the first one, and this is from Chuck Kelly. Chuck Kelly leads MedStar Ambulance down here. A great team of professionals over there. His question is, where is the priority provider spreadsheet? Where can I get a copy of that spreadsheet? So I think that was something that we forwarded out, the initial one after the first briefing back in mid-September. And Carla, correct me if I'm wrong, I think that was provided on that first Wednesday briefing, the larger scale one. Is there anything additional to that original spreadsheet? I thought we sent that one out. But we can resend that. But Carla, were there any additional that have been developed since then?
That's the one. One of the things, I don't know if Teresa Tolar made the call, but we've gotten some feedback from some of the hospitals that some of the information was wrong. And so Teresa has been working with our regional staff to get that spreadsheet updated. So so once that's updated, we'll send out the updated spreadsheet. But that is the one.
Okay, thank you. I know I have another question in the chat, but I will actually toss this one first. Brad, I see your question. We'll get you a second. But I saw Ryan Burke had his hand raised. Ryan, if you're on and you can unmute, you feel free to ask your question.
Dr. Little, in Missouri, they're looking at a more of a regional vaccination plan, kind of splitting it up at two hospitals, one on the Kansas City side, one on the St. Louis side, to get delivery and administer vaccine for hospitals, long-term care facilities in that region, and splitting it up that way. It sounds like Illinois is going in a different direction, but I just want to confirm that. It sounds like all the vaccines are going to go to, a hospital, a long-term care facility, or a health department, and not so much what Missouri is doing.
Possibly. What we're doing is allowing really the local public health jurisdictions and the local and the healthcare coalition to have a say really in how that should work within the jurisdictions. And typically in Illinois, our public health jurisdictions have the primary responsibility for mass vaccination. So we, of course, want to include their opinions on that. And based on the feedback that we've gotten, most prefer, when possible, that the vaccine be shipped directly to the provider. So that's the approach we've taken in Illinois. And you have to think too, a lot of the public health in each state is ran so differently. But in the state of Illinois, since public health jurisdictions are home rule jurisdictions, then we kind of defer to give them that authority and responsibility for mass vaccination.
And Carla, if I might, I know we do have Beth Busman. She is on. She's our emergency response coordinator here in the region. Beth, did you have anything to add to that?
Can you hear me, Phil?
Yes, we can hear you.
So I was not aware that Missouri was creating that. I know that they've been doing some planning. We've been trying to do some regional planning. And Carla's right. The different states are different. Our biggest concern is to make sure that the record keeping crosses the line. So if someone gets a vaccine on one side of the river, they can also get their follow-up on the other side of the river, and it'll all be compatible. But that's good information.
Okay. We did have, and again, we do have a lot more of the slides to go through, but I did want to get one more question that was sent in via through the chat, and this is from Brad Perry.
Hello.
He is our.
Sorry. Okay, real quick. What I need, most urgent.
Hey Chuck, you're unmuted.
Oops.
I got you. I muted you. It's okay. From Brad Perry, HSHS St. Elizabeth's here, right here in O'Fallon. He says, as the county performs their population survey, will hospital staff and patients need included in the county health department numbers? Will hospitals be separate entities?
That's really up. Again, that's where I wanted you all to work together. I would assume that hospitals would have the capacity to receive the vaccine directly. So we would want, and most, by the way, most hospitals, the eye care staff did an audit of the system, and most hospitals in the state of Illinois are already enrolled in eye care. So the next step is, once that CDC agreement is available in eye care to complete, then we would want all of the hospitals to go in and complete the enrollment form, the CDC vaccine provider agreement, so that they can receive the vaccine directly. That would be my recommendation, but also I think it's important to work with your local public health jurisdiction to make sure that they're in agreement with that. We want to make sure that all the public health jurisdictions, that the healthcare coalitions know where the vaccine is in their region. Time, who are the providers, who's ordering it, we want them to have access to that information at all times. So that's why we want them to work together. But I would say, as a hospital, you should be able to receive the vaccine. What we would like you to do as a hospital is number 3, right? Looking at your essential personnel, just the essential personnel only, the hospital, the healthcare personnel, whether they're working directly or indirectly with the patients. We will need that number that goes on that allocation spreadsheet. And then the next step is we would need that number of that population that you can vaccinate on a daily basis. So that's what goes on the allocation spreadsheet for the hospital. The patients, if the patients don't fall into the priority groups in the beginning, then we're like, according to what the CDC is telling us right now about priority groups, phase 1A, phase 1A is just will be healthcare workers, right? And the first responders like EMS, fire, police. Phase 1B, then we get into those priority groups like the persons over 65 years of age, those in and that would be where the long-term care facilities would fall in phase 1B. But the first phase is really getting those healthcare workers vaccinated. So that's why in the beginning you're just going to vaccinate your staff, and then ultimately your hospital census.
Got it. Thank you for that, Dr. Little. While I have the opportunity, I thought I saw Paula on and just wanted to double check if she wanted to test her audio and maybe take over the this portion of the briefing. Paula, are you on and can you try to test your audio?
Hi, this is Paula Jimenez. Can everybody hear me okay?
Loud and clear.
Great. I apologize for being late. I was double booked, and my Illinois.gov email has not been reinstated yet. So I apologize for those of you who don't know me. Some of the names here are familiar to me. I just returned to the department on contract last week to help with this initiative. I'm a nurse. I was the former assistant division chief of chronic disease at IDPH, but prior to coming back in 2016, I did do 20 years working for two of the largest vaccine manufacturers in the world, Merck and Sanofi. And my role was strictly to deal with public sector. So I'm happy to be back, and let's see if I can advance these slides. Carla, thank you so much for pinch hitting for me. Okay,
so I was going to say, Paula, so thank you again. And we're glad to have you. What I'll do is just tell me, all you got to do is say slide and I will move them along for you. I think we're right now just really on the second slide, that take home message. So I think Carla did a wonderful job going over this portion. And we had a small Q&A here, and I think we can pick up and then prepare for another Q&A after you're done.
Okay, that would be great. We can move on to the next slide. So what we're going to do is to deal a little bit more into the each section and kind of review the homework and give you a little bit of background. So Phil, you can move to the next slide. Okay, next slide. I don't know if they're moving for me. I'm seeing number 1, review and update mass facts. Is that what you're seeing?
No, so right now it should be on the state of Illinois mass vaccination goals and objective and the 80% of Illinois citizens.
Okay, I don't know why it's not moving on mine, but I can pull it up elsewhere so that. Okay, here we are. Now it's moved for me. Okay, so the overall goal of this program really is to immunize 80% of Illinois citizens according to CDC guidelines. And we know that that's the magic percentage that they want to see that's going to induce herd immunity. So potentially there could be 2 doses of a COVID-19 vaccine. And usually with new vaccines, it's like a prime dose and then a booster dose, but we won't know that for any certainty until the vaccines actually get approved. Next slide. Okay, so these are the 5 overall objectives of the Illinois mass vaccination program, and that's really, you can kind of read through them for yourself, to ensure the safety of response personnel and citizens, preparing public health, and that's kind of what we're doing now. We're having you guys work within your local jurisdictions, your healthcare coalitions, We also want to coordinate vaccine distribution to the local providers, so that's going to have to be done as the vaccine rolls out. We're not going to get it all at once, and so there will have to be some distribution guidelines. We'll respond to requests for additional supplies that you may need, and we'll review those in some of the next few slides, with the overall goal of really just to mitigate the COVID-19 disease propagation. Next slide. Okay, so we're gonna take a deeper dive into, so what I'm going to do now is to go through some assumptions that we are putting in place at IDPH regarding vaccine distribution, the priority groups that Carla alluded to, and then the actual vaccination. Next slide. Okay, let's talk about the vaccine distribution first. So we're not anticipating, but we want to plan for, definitely, to make sure that we could receive vaccine as early as November. Now, I mean, do I realistically think that's going to happen? It doesn't matter. And do you realistically? It doesn't matter. That we want to plan, and be prepared. We know that the vaccine supply should increase substantially. You guys have all heard on the TV, there are multiple manufacturers that are involved in this initiative. And so they are going to roll out and be approved sequentially. So there could, we just don't know at this point. The major take-home message here is that vaccine providers will be required to enroll in eye care. And our staff has been working on kind of a decision tree as you're looking to see whether or not a provider is really able to do that. There's a decision tree that will be coming out shortly to you, and that will very easily determine whether or not they're capable of receiving the vaccine. Vaccine providers will be allocated vaccine as it becomes available, and that's really based on the disease burden at the time and the overall jurisdiction, and that's why you guys have these spreadsheets that were distributed. The vaccine is going to be delivered through the VFC program, directly shipped to the provider. Next slide. So we know an assumption is that we're all susceptible to the virus, right? So the initial populations, those critical populations for COVID-19 vaccine will most likely be the following populations, and Carla already alluded to those: the critical workforce members, healthcare providers, also staff and residents in long-term facilities and assisted living. They're that 1B population. And then other critical workforce members that provide essential functions based on the governor's executive order 2020-32. We also are assuming that the recommendations for the target groups are likely going to change after the vaccine becomes available, because it really depends on the presentation of each vaccine. It depends on the supply and also how the disease, we know that certain regions in our state become hotspots. So that will all be factored in. And due to the uncertainty of vaccine production for COVID-19 vaccine, really just realizing and knowing that maybe what we tell you today, we may be telling you something differently based on CDC guidance tomorrow. So remaining flexible and adaptable because of high demand or low demand situations. Next slide. So for vaccination, we are assuming that adequate federal funding will be available to implement a large scale project like this. The initial doses of this vaccine will be authorized for use under emergency use authorization, or EUA, which is issued by the FDA based on available safety and efficacy data for the vaccines. We also know that there's going to be many different presentations. So it could be a refrigerated vaccine, it could be a frozen vaccine, or, you know, we know that it could be an ultra cold vaccine. And so those considerations on who can take an ultra cold vaccine will need to be made. The vaccine is going to be shipped in 100 dose increments and kitted with the ancillary supplies. I did just hear on a call this morning that Carla and some others had with the CDC. The ultra cold vaccine is going to be shipped by 1,000 dose minimum. Next slide. All right, so we know when we're vaccinating that we're going to assume that this is going to be a 2-dose regimen, okay? Separated by either 21 or 28 days. We won't know until we see the actual indications and packaging. And our goal is to immunize 80% of the population. And so this is going to require very close tracking of the vaccine administered and really tight patient reminder and recall for a second dose. And so the actual project could take many, many months and will unfold in phases as more of the vaccine becomes available. Next slide. There are many different presentations in development right now. So, I mean, gosh, you know, when I started working in immunizations like 30 years ago, it was pretty simple. There were some frozen and, you know, there was inactivated. Now you see all these different presentations. So there's the messenger RNA with vaccine. There's a non-replicating vector where there's just certain proteins of the virus that will stimulate an immune response that's strong enough to prevent the disease. Protein adjuvant. So an adjuvant is merely something that's added to a vaccine that will kind of boost or enhance that immune response. And then live attenuated vaccine, that's been around for a while in the form of like MMR vaccine is a live vaccine. Chickenpox and herpes zoster are live virus vaccines. And those are when, you know, the virus is live, but it's just enough to solicit the immune response, but not to replicate disease. Next slide. So the CDC is going to provide the communication materials on emergency use authorization for us. It's going to probably be very similar to a VIS, the vaccine information statement, and then we will roll that out, the specific communication to vaccine providers. Again, monitoring for adverse events is going to be critically important here because there's going to be multiple presentations coming out. And so it's going to be very important that if there are adverse events that we know which vaccine. It's highly likely that vaccine A comes out and there aren't many adverse event reports coming in. Vaccine B comes out maybe 2 months later, and all of a sudden we're seeing the adverse events pick up. This is the information that's going to be really important for the manufacturers, for the general public, for CDC to know and manage. So keep track of that. And they do monitor those very, very closely. Vaccine distribution shouldn't alter routine procedures for routine vaccines that we see. And seasonal flu vaccine production continues, and the campaigns to immunize for flu will continue and are very, very important. And we are also going to assume that the demand for the COVID-19 vaccine is going to be really high. Please note that the requirements for COVID-19 vaccine administration will evolve over time as the different presentations of the vaccine become available. Next slide. So when we take a look at the scope of what mass vaccine administration is going to look like in Illinois. So here's just an example, an assumption. So we know that in Illinois, our ultimate goal is to immunize 80%, right? Illinois population is 12.6 million. And so 80% of 12.6 million is 10.1 million. Now we're going to carve Chicago out of this group because they're their own CDC project and they will kind of be doing their own thing. And so their numbers are pulled out of here. So really it looks like just a little over 8 million doses will need to be administered, excluding the city of Chicago doses. So the last time that we did anything like this was 11 years ago now, in 2009 and 10, when H1N1 was around. And so H1N1 flu vaccine, I mean, it was a little bit different. This is going to be on a scale much higher, even though we were trying to get those H1N1 doses in. We know that the COVID-19 vaccine is a little different. So the big impetus for the H1N1 mass vaccination was because you were seeing a strain of H1N1 that was not in the current flu vaccine back in 2009 that was causing some severe disease and some mortality. So it's just a little different. Next slide. The Illinois mass vax strategies are really looking at a whole IDPH and whole government approach. And by that, we mean that we are going to be developing plans specific to COVID-19 and identifying systems and strategies for a statewide immunization. So this is really going to involve a very multidisciplinary group of immunization stakeholders. Many of you are on the call, public health preparedness, EMS, healthcare, hospitals, you can see the whole list. And we've got a stakeholder engagement slide that lists all the partners. We want to commence iCare enrollment to ensure that all necessary providers are registered in the state's immunization registry system. So not every provider may want to or have the capability to administer vaccine. Okay, so that's where the Healthcare Coalition and your local public health jurisdictions, you're going to help us determine that. So, just because a provider says, oh yeah, I want to administer it, there are checks and balances in iCare that will, questions to be answered and screening that will help you determine if in fact they are able to accept vaccine. So the mass vaccination planning guide that was released in early September to local health departments, hospitals, long-term care, et cetera, that really should be your guide in planning, ordering, administration, and tracking. So we're using that, and then we're using the key components of that mass vax planning guide to guide the exercises. So certainly there will be situations in different regions, and there will be some questions, that come up specific to your region. And we will be developing training on the key components of this and rolling that out. Next slide. Okay, so more on the strategy. We're going to build on lessons that we learned, things that we did well in H1N1, and learned from the also the Crimson Contagion FE, FSE. There are, we know where there were gaps with those programs, and we have updated State of Illinois pandemic plan to include the COVID-19 component and the vaccination plan. And then really, it's to really develop top-notch administration tracking. So as we said before, there's going to be multiple presentations of the vaccine. There are different options available to us on how we can track the vaccine. So CDC has a system called VAMS, which is the Vaccine Administration System. There's also EM-Track, which is a patient registration and tracking system. So there are different platforms for which we can track the vaccine. And so education of providers and the public are going to be very key to the success. Next slide. Vaccine safety is always paramount. The CDC does have a mechanism, has had it for many years, on which vaccine adverse events can be reported online. This is called the VAERS system, the Vaccine Adverse Events Reporting System. We want to also ensure that the IDPH hotline updates its messaging and has a link to the VAERS site. AEs will also be monitored through the CDC through electronic health record and claims-based systems such as the Vaccine Safety Data Link. So there are several ways. Additional safety monitoring can be required under the emergency use authorization. So just be aware there's a system of check and balances and double check with all these different systems that are available. Next slide. Vaccine implementation. So here you see a organizational chart with Dr. Lathan and Dr. Little as our heads of the mass vaccination program. What we're asking you to do, you can see under vaccine administration division that we want you guys to identify task force leaders. So these task force leaders in your region or within your healthcare coalition, you know, we want those leads to, you may have a lead for local health departments, you may have a different lead for hospital providers, a different lead for long-term care providers, and then other or private providers. So, I mean, these are the kind of leaders, and this is how we're splitting it up at central office. We have different point people, and this is something for you guys to consider in your individual regions. Next slide. When we go to track the overall vaccine administration, we'll do that a couple different ways. We will track it by patient and also tracking adverse events as they're reported. We talked about the different ways that that can be done and the different reporting. But again, a very, very critical and key piece. And I mean, I know from working in the vaccine world that typically adverse events tend to be underreported, but even the mildest one, you know, I think we can't drive this home enough. If a provider, you know, sees anything where they just feel in their gut is not right, it's, to me, I think it's better to over-report than to under-report, especially with the COVID-19 different vaccine presentations coming out. Next slide. The vaccine division at IDPH oversees the administration of each provider type by region. Now you guys were, you know, we've split the state into regions 1 to 11 corresponding to the EMS and public health regions. We want to make sure that the vaccine that you're receiving is, and Carla talked about this a little earlier in the presentation, promptly utilized and tracked. So what we don't want to happen is hoarding of the vaccine, which occurred in H1N1. So that's where those allocation, when you're trying to figure that out, you need to understand the capacity that you have and how much, I mean, you should be thinking about how much vaccine, once you get it in your hands, to a way to distribute that vaccine and administer. So distribute and administer within 24 to 48 hours of it being received. So again, that's going to prevent hoarding, etc. We'll be collecting reports by provider types, public health jurisdictions, and regions. We will be communicating daily with Dr. Little. We'll be at central office, we're going to be talking daily about how much vaccine we are getting, what jurisdictions are, what the allocations are going to look like. So it will be a multidisciplinary group working at central office alongside of you. Next slide. For eye care, the big thing here is to make sure that appropriate providers are enrolled. And so once you guys get that decision tree, it's going to be a lot easier. You may be able to check them off your list right away. As Carla said, most hospitals are already enrolled as a provider, so re-enrollment would not necessarily be indicated. And we will be providing training and technical assistance to the vaccine providers. Next slide. The RSS and distribution group, tracking vaccine distribution from the CDC to the providers in the state. So remember, these first doses are going to go directly to the provider, and we'll be asking the providers to keep very detailed records on every shipment. We will be monitoring all shipments and all the timelines for shipments. So there had been questions in the past about, how will you know, if this is coming and how much you're getting. We will be tracking all that in central office. There will be daily reporting. So doses of COVID-19 vaccine that are administered will be required to be entered and reported daily to the MCM branch director, which is Dr. Little. Next slide. Identifying the priority providers. Next slide. Carla talked a little bit about this. So definitely the first in this group are hospitals. So that sheet has been given to you previously to fill out. And let's see if I can get this echo to go away. Is that any better? Does that echo? Yeah, I'm not.
Yeah, I don't hear an echo. It may, Jackie, that may be on your end, because I'm not hearing an echo currently at all.
Okay.
No echo either.
Yeah, and the other feedback I'm seeing, they're not receiving any echo.
Okay, I'm sorry about that. You can just try like maybe turning your volume down on your speakers or headphones that you have. So the priority vaccine providers by region, you guys were sent that sheet. Those sheets were supplied to you. Needing to check through those and make sure that the information there is accurate and complete. Next slide. Calculating the estimated number of essential personnel for providers. So the minimum order size is 100 doses for most vaccines. We just found out yesterday that the ultra frozen is going to be minimum order of 1,000, but just wait for more guidance for us. So certainly in some of the smaller counties may not receive an allocation for ultra frozen if they don't have the capacity for storage. So, those are all things that we ask for your help in as you plan and assess. So the vaccine, if an adjuvant is necessary, that will be shipped directly to the provider's destination within 24 hours of orders received. The ancillary supply kit, you can see that it contains some, but not all of supplies that are needed. So it does not include your sharps containers, gloves, bandages, but it will contain some PPE, and you can see how that is allocated there. Next slide. So the CDC recommends that face masks be worn during this mass vaccination for all healthcare providers. The N95 masks are not recommended. Eye protection in areas where you do have moderate or substantial community transmission, you would probably want to use eye protection, and it is optional in areas of minimal or no community transmission. Gloves recommended for intranasal or oral vaccines. They list optional for IM or sub-Q vaccines, but definitely go with your own local infection control guidelines. And what I would say, take home message here is you can always do more, but not less than what the CDC is recommending. Next slide, please. Determining the maximum vaccine administration capacity of each provider in the jurisdiction. Again, this is where you all come in. Next slide. These are daily vaccine allocations that are listed. So you can see that the larger counties do have higher daily allocations than the smaller counties. And knowing what we know, that only maybe a small fraction of vaccine is going to become available, these numbers then become even smaller. So this is what we will be using in central office as we determine those initial allocations, who's getting, what county is getting what vaccine and what amounts, et cetera. And that'll be based on different factors. So certainly, like if one county isn't experiencing any cases and there's another county that's just blowing up with cases, we may adjust those allocations. So just be aware, be flexible and adaptable to that. Next slide. Again, more on allocations. I know we're running short on time, so you can kind of read through that. We've talked about the priority groups kind of ad nauseum here, just knowing that you should anticipate that the allocations may shift like we just said. Next slide. Collaboration is key here. Next slide. So collaboration is key as we develop training plans in your jurisdiction. So providers and key stakeholders will need to know how to order and track the vaccine storage and handling, everything that you see here, and we will guide you. IDPH will guide you, and we will be referring to CDC guidance here as well. We will look at any gaps you have. So go ahead, next slide. Next steps are to ensure that the plans are aligned at the state and local levels. Second is to set up a regional meeting to collect data, provider types, and vaccine administration capacity. This is where you guys are really helping us here, because your area, we don't. You're going to help inform these numbers here. Number 3 is to ensure all providers are enrolled in the needed system. So like iCare, Siren, Illinois Helps. And once the vaccine is released, tracking and monitoring for adverse events. Next. These are the resources at your disposal, and you should become familiar with all these resources. You should have already received these resources. If not, please let us know. And that is all I have. If there are any questions, I apologize for going over.
Thank you, Paula. No need to apologize. So thank you. There are a few questions that I think did come up in the chat, and some that were sent to me via email internally and externally, that I'll kind of start to lead us through. So again, if you do have questions for the team, for the IDPH team, please, if you're logged on via Microsoft Teams, use the raise your hand so I can kind of appropriately go through and make sure that your guys' questions are answered. And then once we get to a point where we're done with those questions, we will go to any audio questions for those who are just called in directly with the phone number. So please hang tight. So I will start off. I have 2 questions here, and then we'll move to the 2 that are in the chat, and then we'll go to Sue Laughlin after those, as I see she has her hand raised. So I'll start off with this first question. Can a single HSO or hospital requests to receive the allocation for multiple HSOs within the hospital system for redistribution and or administration. And I'll give you kind of an example, and I'll use BJC for an example, our healthcare system. We have 3 Illinois hospitals within BJC. On the Illinois side, Memorial East, and then we have Alton Memorial that's up in Madison County, and so it's further north. Just based on the storage requirements and space or allocation, could one of those hospitals, and I'll say Memorial Hospital here in Belleville, receive that allocation and then redistribute as needed for those frontline staff or those priority group staff?
I, being the newbie back into the immunization scene last week, I am going to shamelessly punt this to Dr. Little.
Maybe you might be a Dallas Cowboys fan. Maybe they do a lot of punting. No, I don't mean to say that out.
They do shameless punting.
I'm just
no shade, huh?
No. Carl,
I'm sorry, I didn't hear the question, Phil. What was the question?
The question was, can a single hospital or HSO within a system receive the allocation for multiple HSOs within that system for redistribution and administration? And in the example I gave, we have 3 Illinois hospitals in the BJC system here: Memorial, Belleville, where I'm at, Memorial Hospital East, and Alton Memorial, that's up north, Madison County. If they didn't have the capability to store at Memorial Hospital East or at Alton, could we at Memorial Hospital Belleville receive their allocation and redistribute or administer to the staff there, the priority staff there?
Yes, I think that's a great idea too, and that's why it's very important for you guys to be collaborating not only as within your public health, the county, but also within the region, and not just in hospital systems. Because say if one hospital system opts to receive for their system, that may overlap various counties, right? And does it in that case. So we want to make sure that all of the public health jurisdictions know what's going on and how the vaccine is being ordered and received across the region. So yeah, so that is a very good example while we're suggesting this kind of regional approach to thinking about it.
Thank you. And the second question, dispense assist. We've included that in a lot of our plans and programs, and it just so happens that we've been looking at this a little while ago, but we noticed that you guys have that in your briefing as a tool, and we think it's a great tool, especially for flu, et cetera. But I'm not sure if the Johnson County folks did not either maintain the system fully because the apps are no longer available on iOS and Android, and the algorithms that are available still are only for plague, influenza, and I think rabbit fever, and maybe something else, anthrax. Yeah, so tularemia, plague, influenza, and anthrax. So there isn't a screening algorithm for COVID-19 to use dispense assist. So, we've been trying to think about other methods that may be able to assist. And again, I think we're looking more external because that wouldn't be something that we might use this time for internal here at BJC. But some other hospital may want to use that. So has there been any conversation back with the folks at Johnson County, and I think it's in Oklahoma, with regard to updating the app to include some type of algorithm? And I haven't, and again, just haven't seen one, probably because we don't have a bona fide singular vaccine yet.
Right, and I think maybe that's why. And I'll before I turn it over to Beth on the call to speak to this a little bit more, because I was on a call early on with Beth and the region, and they were talking about possibly using dispense assist. I thought the Missouri side was, so I wanted to make sure we left that as an option for the Illinois side as well. But I'll turn that over to Beth in just a minute. But what I did want to say about that is the other systems that where there's that we're looking into also are VAMS, that Vaccine Administration Management System that CDC developed. Well, CDC didn't develop it; was developed by APHL, and they're planning to use it. See, one of the earlier suggestions from CDC was that they wanted us to use it for priority population registration. So like in phase 1A and B, but they kind of, it looks like they're trying to move away from that. But that is a system. It's being demoed. It has been demoed, and it's in development right now. There's going to be some training they're rolling out on that. So that's a possibility of a system. And then the other possibility is EM Track. EM Track, already has, that's already in the state of Illinois as a part of that. What is that Javari suite that includes WebEOC, Siren, Illinois Helps, EM Resource. So EM Track is part of that suite. And they have a patient tracking module and a vaccine module. They did some trainings a couple of years on that system, EM Track, and that was one of the systems we were planning to use for the full scale exercise. So that's another option if Dispense Assist is not available. Now, what we're doing, we're having a meeting on, and I think there may have been a meeting yesterday as well. We were otherwise engaged, but trying to decide how those systems interact with each other. So if you guys are all familiar with eye care, I guess a lot of the hospitals and providers currently that use eye care, they send the data through their electronic health records through some type of HL7 interface. So that is an option for those systems as well. We're going to provide more information and more training on those systems. But just to reiterate, there is already the EM Track that's in the state that can be used. Then there's also the VAM system that can be used. And then we'll find out more about Dispense Assist, and I'll turn it over to Beth to see what she knows about Dispense Assist.
Thanks, Carla. So I have been in touch with Johnson County and their development team, and they are looking and updating the system. But as Carla said, they can't do the final versions until they know what vaccine is approved to build in that algorithm. They said that they can do it quickly. The system is set up so you can do it, within a few hours. But I haven't talked to them for a few weeks, so I'm not sure where they're at in the process. My hope, because we're dealing with so close to two different states, is whatever system we use, be it Dispense Assist or EM Track or have their that as long as it's compatible with iCares and it can roll up then into the CDC system, that I envision and hope that we will have several options that the providers can use whatever works best for them, whatever they're most familiar with, as long as they're all compatible. But I will add that to my list to reach out to Johnson County again to see where they're at with their system. The Kansas City CRI jurisdiction, they are planning to use Dispense Assist as of a few weeks ago. Thank you.
Thank you, Beth. Okay, we do have a few more questions in the chat, but I'm going to go over to Sue Laughlin out at Staunton. Sue?
Hi, yeah, this kind of follows after that first question about facilities ordering the vaccine for a group of hospitals within a system. We do belong to another hospital. We do not currently have an iCares account though, and the question I have is, do iCares accounts need to be individual, or can that ordering facility of the vaccine carry the only iCares account for the system and report all of the administration of the vaccine, the tracking portion of it, on iCares?
So that question,
I can go ahead and take that one. Sorry. So Staunton, so you're with the hospital?
Staunton Hospital is a member of Anderson Healthcare. So Anderson Hospital currently is working on their iCares account, and they
So they'll
they
order
felt
the
like
vaccine for
that
everybody.
account would be enough for both of us. I
Okay.
just wanted to make sure that we don't need one of our own to track our administration of vaccine within our facility, or can we share one iCares account between the two of us?
Yeah, so the way oh, go ahead, someone speaking. So the way iCares work, so Anderson will is enrolled in iCare, and they will order the vaccine for you. So they'll sign the vaccine with the state and with the CDC, and they'll be ordering the vaccine for both hospitals. Is that what you're saying?
Yes, that's what I understand, but through this presentation, I feel iCares is also utilized for the administration tracking portion of the vaccine program. So not only ordering, but also reporting. Is that correct?
Right. So what that goes back to the systems that we talked about, whether you're using VAMS or Dispense Assist or EM Track, you should be able to use those systems, like have so say for instance with VAMS, the one they're really promoting by CDC for use with phase 1A and 1B vaccine recipients. You can send them send your hospital staff that will be vaccinated a link. They will register in VAMS, right? That information is supposed to then be uploaded into iCare via some HL7 technology that we'll have to get you more information on from the IT people. So you still may not need to have a enroll in iCare. Or another option is your hospital. So Anderson is the iCare provider. They're ordering the vaccine, but maybe you want an individual user from Stanton or Staunton?
Staunton.
Staunton, yep. I've been there before, I believe. So Staunton, you would want them to be enroll in iCare as an individual user under Anderson if you wanted to be able to have visibility in iCare. So that may be another option for you with on how you use iCare.
That's good. I just wanted to make sure we didn't need to have that account to report anything, but if they're going to use VAMS or Dispense Assist or whichever one they choose, we'll just report out in that and let Anderson keep the iCare account and order what we need.
Right.
Thank you
Now,
for the
because
clarification.
oh, no problem. Because my other question to you, like when you guys do you do flu, like seasonal flu shots now?
Yeah.
And how do you guys keep data on that and report it up into some type of electronic health system?
I'm sure we do, but that would be a question for my infection control nurse, and she's not with me right now. I apologize. I know we've had a long-term flu vaccine program, and I know that she reports some information somewhere, but I don't know where.
Oh, okay, because check with her because that system may also have the ability to report to send that information over to iCare as well.
Okay.
Okay,
Thank you.
you're welcome.
Great question, Sue. Thank you for the answers there. Just a few more questions here in the chat that I think would folks would really like to have some answers to, which would be great. First one I'll go to is Paula Campbell's question. She says, in the iCares document, what do the color coding on the Federal Qualified Healthcare Centers page, what do they mean? It says there's green, yellow, and a few with no color or highlights. I know we don't have that right here up on the screen, but do you know those offhand?
Yes, if you scroll down to the bottom of that, of each of those tabs, it gives you the color coding is explained, what the reason, and that really was kind of an internal way we were using the documents to say what entities were enrolled in iCare and what entities still needed to be enrolled in iCare. So that was kind of how we were using that information. It really doesn't mean as much anymore. So we're gonna, when we resend that document out, we'll take the colors off of it But at the time when we sent it out, it meant more then than it does now. So it was our way of tracking. Many more entities have been enrolled in iCare since that document went out. But one thing I wanted to say is that all of the hospitals actually, from what I understand from the iCare staff, had iCare, some type of iCare account. So.
Gotcha. And she says, thank you.
You're welcome.
This one is from Chuck Kelly at MedStar. He says, "Will participants have the right to refuse, and will there be a declination form for it, similar to what we do for Hep B and influenza?" So and I guess I'll jump on top of that question. So once we're talking about our targeted population group, and I'm for providers and healthcare workers. Is that going to be something that they can opt out of once they are identified as essential or what have you, the key provider group?
We have not talked about a declination form at the state level because right now the plan is not to make the vaccine mandatory. Our goal is 80%, to target 80%. Our plan is to reach 80% of the population with the vaccine, but it's not a mandatory vaccine at this point. If the governor's office decides to make that mandatory through some type of legislation or emergency order, then I think we would have to cross that road when we got to it. Or if an entity would decide, similar to what they do with the flu vaccine, that they would make the COVID-19 vaccine mandatory, then I think that would be a conversation that would needed to be had by that entity. But from a state planning perspective, it's not. We're not planning for it to be a mandatory vaccination.
Thank you, Dr. Little. And as a follow-up, he had a statement here underneath that. And Chuck, if you can unmute, it's probably best maybe if you ask it, but I'll try to paraphrase it. But basically saying that he has providers that work both sides in Missouri, that reside in Missouri, excuse me, and in multiple counties in Illinois. Basically asking, will he need to be able to, he'll need to be able to direct them to local health departments. So, Chuck, and again, if you can unmute, is that specifically asking if the declination was necessary and who they go talk to? So I don't know if you can further clarify that or ask that question out loud yourself.
Originally, when I had brought this out to the local health department, the question was during our influenza pandemic plan, is we were going to have a centralized distribution for our organization, and all our employees would go to a centralized location. Well, now I have employees working that work full-time in Illinois and live in Missouri. Missouri is handling it differently than Illinois in how they're going to distribute these vaccinations. Trying to figure out, okay, somebody lives in Calhoun County, just the only county out there, but they work in St. Clair. Do they need to go through do they go through St. Clair County with me, or do they go through Calhoun where they live, especially when there's so much tracking that has to be involved with these particular vaccines?
I don't foresee that any resident would have to go to their particular county health department or a provider in their county to be vaccinated. If they're, and this is where Beth and Greg come in, because any plans that we have on the Illinois side, we want to make them also compatible with what's happening on the Missouri side. So I'm not sure. Who do you work for?
I work for MedStar Ambulance. I cover Roundoff, St. Clair, and Clinton counties.
Okay, yeah, because I know that we're looking at plans for how EMS professionals would be vaccinated through their EMS through the resource hospital. So I think so that would be worked out, but also especially because EMS personnel would be in that phase 1A group. And so I think Greg could probably answer this better than I do, but working with Ashley Taylor, who is now the EMS director for the state, I know we're working to ensure that the resource hospitals would have the capacity to vaccinate the EMS professionals. Is that correct, Greg?
Well, yeah, so the resource hospitals have to come up with a plan. None of the resource hospitals have submitted a plan. I think many of them were waiting for some of this information to update plans and submit them. But that would be for for them to be able to, or the providers to be able to provide the vaccination and track it. Beth could probably speak more to, because I think this question has come up about working in one county and residing in another. Didn't you have a discussion about this, Beth?
Yes, this has been an ongoing issue for years and years, especially across the state line. When you're dealing with what we would consider a closed pod in your case, and especially a high priority group, it's best to keep those clients out of the local health department, because they're going to be dealing with the open pods and the general public in their own priority groups. So we've always assumed that the employer, which in this case would be the hospital or the EMS provider, would vaccinate their own staff regardless of where they reside. Doesn't matter what county or what state, if the employer can provide the services, provide the vaccine, then that's what we encourage.
Okay, I'm just involved in writing our Region 4 plan for EMS, and that's why I'm participating on these calls, asking these questions, because if I need to modify the procedural and things, I need to know how we are going to handle it as a closed pod that way.
So I would encourage that you include all of your employees regardless of where they live. Thank you.
Thank you very much.
Thank you, everyone, for those answers. So we've gone throughout the chat questions and the few that we did have open for the raised hands. I would now like to just open it up for the folks who maybe called in directly and weren't able to ask a question yet, but have a question they'd like to have answered. So we'll try to do this as best we can. But if you are to ask a question, please unmute. Make sure you don't have on any other versions of this call, so we reduce the amount of echo potentially. And if you're not talking, please make sure you mute until it is time for you to talk. So I will open it up for questions here. We'll go for another 5 or so minutes. So the floor is open for any additional questions.
Hey, Phil, this is Michelle with Madison County. I just have a quick question about the iCare enrollment. The iCare team mentioned that there is going to be additional guidance coming out on eligibility requirements for certain providers to enroll into iCare. Do we have a date when that will be released?
Michelle, this is Paula. I mean, are you referring to that decision tree that I presented on, or?
I think there's a little bit more information on regarding who can enroll into iCare. I guess depending on like their capability to receive or cold storage and capacity, et cetera.
Yeah, that's pending approval. It's already been written, but I think it's going through the approval process with the Office of Health Protection. So I think the goal is to get it out fairly soon. I think within the next couple of weeks, that should be out. But are you a hospital or what entity are you?
I'm from the Madison County Health Department.
Okay, so Madison County Health Department, I believe all the health departments are already enrolled in eye care, but the next step would be for you to complete that CDC provider agreement, the vaccine provider agreement form, which again has gone through the approval process with IDPH Legal, and they're updating that in to get that in eye care as a fillable form. But from a Madison County perspective, you guys should have a plan for mass vaccination already, Michelle. And
Correct. I was just
okay.
assisting other providers to get them enrolled.
Oh, okay, good. You were scaring me for a minute. But
So Carla,
oh, go ahead,
in
Beth.
Michelle's defense, yeah, I have encouraged the health departments to get those, make sure the hospitals are enrolled, try to get the long-term care facilities, their major closed pods, to go ahead and get them enrolled in eye care. And it's to the point where some of these facilities are starting to get rejected. So it would be good to have that decision tree so the health departments know who to encourage to enroll and who to not bother spending the time with because they know they're not going to be approved to begin with, if that makes sense.
Yeah, that does make sense. And we have been working with the Division of Long-Term Care on that issue too, early on to try to push through those enrollments. And and that's why the eye care staff are coming out with that decision tree. But for instance, if you're a long-term care facility, Michelle, until that comes out, here are the recommendations that eye care staff have and we've been pushing out as in terms of long-term care facilities. If the long-term care facility has a medical director that can sign off on the prescription or to do the blanket prescription for the COVID-19 vaccine administration to staff and to the residents. And if they have the ability to store the vaccine according to the CDC instructions, when that comes out, then they should register as a provider to receive the vaccine directly. Otherwise, we would want the long-term care facility to work with the local health department as a closed pod, have the local health department receive the vaccine, and then administer it to the long-term care facilities, similar to what a lot of the local health departments plans that are already in place. Another option that you'll hear more about, because we're just learning about it, is that the CDC actually is working with two large national pharmacy chains that are already working with long-term care facilities across the country. They may administer like the vaccine programs such as seasonal flu, for example, to sign an agreement that they would also vaccinate in long-term care facilities. So we're waiting to hear more about that. Once we hear about that and know who in Illinois is participating and where they're participating, we'll send that information out to this group so that you have it. We'll send it, to Greg, Beth, and Phil, and then they can disseminate it out to this group. But that's one of the other plans that is coming on board for long-term care facilities. Does that help?
Yes, thank you.
You're welcome.
Thanks, Michelle, for that question, and thanks, Dr. Little, for the response. Okay, I think, do we have any other call-in questions? I know we just received another one in the chat. Do we have any additional call-in questions? Okay, so I will ask this one from Danielle Rahman out at our good folks at Gateway. Says for hospitals that own physician clinics, should each clinic be registered as a provider individually, or should the hospital manage the ordering and receipt for all owned clinics? This will apply in phase B when those older than 65 are included in the administration priority group. I know that's a similar question to what we had earlier. How does that factor into the eye cares situation?
Yeah, I think what in that case the facility should look at the way how they manage the, say, influenza vaccine, the seasonal influenza vaccine. Do they order it centrally and then distribute it out, or do they have each individual clinic order and receive their own allocation of the vaccine? And if so, depending on how their normal processes work, my suggestion is that they would mimic what already works well and do that. So that would be my recommendation. But again, I'm going to turn it over to Greg and Beth because they're working more on the regional and local plans, so they may have a different perspective.
Anything additional to add, Beth?
The only question that I have, and I am not the eye care expert, is if that's allowed through eye care. For example, I know, for example, the flu vaccine, if a health department wants to conduct an off-site drive-through clinic, they have to get special permission from the eye care. So I'm not sure if the eye care is going to follow that those same guidelines for the COVID vaccine, and only the approved location where the vaccine is shipped will be allowed to administer the vaccine, or if they provided to be allowed to send the vaccine out to satellite doctor's offices as described. That's the only question that I have, and that's why I haven't provided any potential
Oh, yeah, somebody put us on mute.
I see, and I'm trying to see if I can mute them now.
Yeah, and that's a
Here we
good question, Beth. That will be the difference, I think, with the administration of this COVID-19 vaccine, because it's just, again, similar to what we did for H1N1, where satellite clinics, especially by the local health departments, the open pods are basically considered satellite clinics, right? So we have to put out some guidance on that, because that will be allowed and that will be necessary for, to really saturate the area with, and make the vaccine clinics convenient to those people that need it the most. So we'll put some guidance out, but yeah, so the short answer is yes, that will be allowed, and then we'll put out some guidance on it. So I would say in that case, with the seasonal, the way the hospital works with the satellite clinics for seasonal influenza, my suggestion is they would work the same way, just to stay consistent, with the understanding that a lot of that data, who the vaccine is administered to, would need to go back into eye care using, one of their, whatever system makes the most sense to them to use, whether it's VAMS or EM Track or Dispense Assist or, whatever electronic health reporting system that they already have in place. But we'll get some guidance out on that. We'll put that in one of our FAQs. Okay.
Thanks, Carla. I just got a message from one of my health departments. They're telling me that rule only applies for the Vaccine for Children program. Again,
okay.
It would be good to get some clarification. And second thing, make it very clear who is responsible to enter the electronic medical records.
Like who, like what role?
Is it the provider who we ship the vaccine to, or is it going to be the the person who actually gives the vaccine off-site.
Okay, yeah, it should be the on-site people, but we'll make that clear. There should be some, my suggestion really, like we do with our plans already in place, is you have data entry people. So you know how someone enters the mass vaccination site, they've either registered online and they would bring that QR code that can be scanned in to the system, and then the screener would ask those questions. Everything's uploaded into the system and ultimately into iCare. So I think the data entry people would be the ones, but we'll put out some guidance on that too.
Yeah, either way, I just think we probably need to make that clear. Thanks, Carla.
You're welcome.
Great questions, everyone. So to be mindful of everyone's time, I'll give one last opportunity for one more question from a call-in person, and then after that, we'll kind of just go for a quick closing comments and we'll close this out. So if you do have one more question, you should probably be the first person to unmute and shout it out. So anyone? Okay. Well, at the height of this call, I think we had just a little over 70 folks from across these represented here. So thank you to everyone who joined today's call. I'd like to give a special thanks to Dr. Carla Little and Paula Jimenez for providing the briefing and answering the questions, and then our other special guests that we see all the time, Beth and Greg Atterbury from IDPH for filling in a lot of those gaps. This is what healthcare coalitions do. It's all about collaboration and understanding with each other. Not all of us have the right answers for everything, but together we can, pretty much do anything, especially here in this region. We've got a great reputation for walking hand in hand, especially during a disaster. And this is just another example of that. So I would like to thank each of you for taking the time out of your busy day to attend while we go through this crisis. We are in the midst of it. And the one thing that I ask everyone to do, whether you're a frontline staff member or you're an 8-hour flower or a desk jockey like myself, that's what I like to say nowadays, be a role model. We're all in healthcare, whether you're touching a patient or you're taking out the trash, it doesn't matter. We're all in healthcare. And I'd implore you to follow the guidelines that the good folks at IDPH have put out in line with the CDC to help keep pushing that curve and flattening the curve that we have here in Region 4 and across the state. We've been doing a great job. We've been pushing the numbers down, and it's a testament to what you guys do day in and day out. So I ask you to just be a role model. You don't always have to challenge everybody. You don't see them wearing a mask, but you'd be surprised at how far leadership by example goes in your own community. So if you are out and about, continue to practice that social distancing, washing your hands, stop touching your face, wear a mask. All the appropriate things, and that will pay it forward one way or another. So again, thank you, Dr. Little and Paula. Great work, and we will talk to you guys very, very soon. So we're going to close it out here. This will be uploaded to our YouTube page as a private listing. So make sure, if you haven't already, become a member of our Member Planet site. If you just go to our website at swillhope.org, you can click on the member login and join, and you will have access to these types of videos so you can, revisit them in the future. So thanks again to everybody, and we will talk with you soon. Have a great day.
Thank you.
You too. Bye.